She has used wedge shoe insoles, footwear, gait aids, and braces as biomechanical interventions, and has published over 350 peer-reviewed manuscripts in JAMA, Annals of Internal Medicine, and the British Medical Journal, and a couple of papers in Nature as well, which I know for sure because I'm a co-author on one of them, kindly enough. She was also the recipient of the 2018 Australian Council of Graduate Research Award for Excellence in Supervision, and has been on the ORCI board, which is the International Organization for Osteoarthritis, since 2008. I was very pleased when Kim, about a year ago, agreed. That was loud. I was very happy when about a year ago Kim agreed to be a keynote lecturer, and when she announced that she would bring 2 of her 3 daughters along and make it a little bit of Canadian vacation, I was even happier that we could help her doing that. So it's my great pleasure and also privilege for us and the ISB and the ASB to welcome Kim Bennell to give this last keynote lecture. Please help me welcome her. Good luck.
Thanks. Well, thank you very much, Walter, for that kind invitation. And I must say I feel very honoured to be here speaking amongst such outstanding biomechanical researchers. So I'd like to thank the organising committee, and particularly Walter and Sandro Nig, for organising our talk. And as Walter said, not only was I fortunate to attend the conference, but to bring along the family and to visit some of the most amazing scenery that I've seen. And no, that's not me doing a handstand on the rock. So before I start, just some disclosures. As you heard from Walter, I'm a physiotherapist, so I consider myself to be a clinical researcher. But what I wanted to do today was to really highlight how biomechanical research can inform, underpin, and be embedded within clinical research and within randomised controlled trials so that we can ultimately inform clinical practice. And I'm going to use examples from 2 chronic musculoskeletal conditions, osteoporosis, and very briefly cover that, and then spend most of the time looking at knee osteoarthritis. So for those of you who don't know what osteoporosis is, it's a disease where there is microarchitectural deterioration of the bone and low bone density, which makes the skeleton much more fragile and likely to fracture even under the application of normal loads. And it fractures often in places such as the spine or the femoral neck. And as a physiotherapist, we want to know, well, how can we use exercise to increase bone density and to prevent osteoporosis? And that's a logical question because we've long known that bone is a highly mechanosensitive structure. And I know that our keynote speaker from yesterday, Dr. Ralph Muller, will be looking at this very simplified diagram and having a bit of a laugh. But we know that mechanical load certainly does influence bone, and it can do that via influencing the osteoclasts and the osteoblasts, which are the bone cells responsible for bone formation and resorption through the processes of modelling and remodelling, and ultimately change bone mass and bone density and geometry, and hopefully improve our risk of osteoporosis. And so back in the end of the last century, start of this century, which sounds a long time ago when we put it like that, but there was some really elegant biomechanical research where the researchers used externally controlled loading models in animals to very precisely manipulate and control aspects of the mechanical environment to see which led to the greatest bone response. And what they found was that bone responds really only to dynamic loading, and that the mechanical variables that led to the best response was those with higher strain magnitudes, higher strain rates, fewer loading cycles, unusual strain distributions, and rest periods between the loading bouts. So researchers then said, well, if we're going to apply exercise, based on this, what we would hypothesise that the best forms of exercise would be those that have high impact, that have high resistance strengthening activities, dynamic activities, fewer repetitions, variety of activities that are applied in different directions, and to exercise more frequently with shorter bouts. And so over the years, there was a number of studies, both in animals and humans, where exercise interventions of various types have been tested to see their effects on bone. And we did some studies in rats where we made them run on the treadmill. Here we did a weight training study where we tied different amounts of weights to their tail and made them climb up a rack to reach the hundreds and thousands at the top. We did some studies in postmenopausal women. I must say the animals were much easier to deal with except for the biting. But these studies really did support and show the best interventions in terms of exercise for bone density, and they showed that childhood was the window of opportunity when bone had the greatest response to exercise. And so now if we fast forward to clinical guidelines, and here's a clinical guideline telling clinicians what is the best forms of exercise to prescribe to prevent osteoporosis. And what they say here is that we should be doing high impact loading, and they give some ideas about the exercise prescription. We should be doing high intensity progressive resistance training, and that basically mirrors what those earlier biomechanical studies in animals showed us. And so I think this is a really ideal example of how biomechanical research can really inform our clinical research and ultimately inform clinical practice. So I'm now going to move on and spend the rest of the talk with knee osteoarthritis, because that's where most of our research has been. And we know that knee osteoarthritis, we've heard a lot about it at this conference, which has been great. We know it's a chronic joint condition where there are changes in the muscles and the ligaments and the bone, and it mostly affects the medial compartment because that's where about 70% of the load when we walk goes through, so that's not surprising. So we have these structural changes that you can see on X-ray and on MRI, but from the patient's perspective, what they care about is that they have pain, chronic pain, they have loss of function, problems going up and down stairs. And unfortunately, we don't yet have any drugs that can slow disease progression. And so a lot of people with knee osteoarthritis get more severe and end up with advanced disease and have to have costly joint replacement surgery, which is not always effective and which can have adverse effects. So we know that biomechanics does play a key role in osteoarthritis, and you can see here in this diagram from Saxby and Lloyd that it interrelates to tissue structure, tissue biology, biochemistry, and so forth. But what they have left off is that if we're dealing with chronic pain and we're dealing with people, the psychological factors also play a role, and psychological variables will influence the patient's experience of pain as well as their response to treatments, and the placebo effect is certainly very strong when we treat people with osteoarthritis. But there are a number of neurobiomechanical factors that have been studied and shown to be important in osteoarthritis. Obesity is one, and we know that it's very common in people with osteoarthritis because it does increase the risk not only of getting osteoarthritis, but if you have it, you're much more likely to show disease progression to advanced disease. And we've heard a lot about this at this conference, that it's not just probably the effects of the mechanical effects, but also because of the inflammatory effects that you get with obesity. So it justifies weight loss as a treatment. We also know that static malalignment plays a role, so people are much more likely to have varus malalignment as shown here, and if the patient has this, they are again much more likely to show progression to advanced disease. Some people with osteoarthritis present with varus thrust, which is an indicator of dynamic instability. And you can see this when the patient walks, and it's a sort of a visible outbowing of the knee into more varus during that mid-stance period. And I'm not sure if you can see that here. Oops, for some reason that's turned sideways, but so you won't be able to see it. But nevertheless, if you can see this in a patient, studies have shown that those people are much more likely again to go on to show disease progression. Muscle weakness is almost universal in people with osteoarthritis, particularly quadriceps, but also hamstrings, hip muscles, and again justifies muscle strengthening for the management. Increased muscle co-contraction is a feature, and also particularly increased co-activation of those lateral muscles, which is thought to be perhaps due to protect the joint to help unload that medial compartment. And this has also been shown to relate to faster disease progression. There are gait changes as well, and there are also proprioceptive deficits. But by far the biggest and most studied factor in knee osteoarthritis, biomechanical factor, is the knee adduction moment, and it's been a key biomechanical biomarker for many years. And this describes the distribution of load between the medial and the lateral joint compartments, and some people have used it as a surrogate indicator of the medial compressive force. We know that that has some limitations because the correlation between the two is not always strong. In some studies it has been, but in others it hasn't been, and it may be influenced by the task and muscle activation and so forth. But nonetheless, notwithstanding these limitations, it has been an important biomarker because it's been shown to be related to outcomes that are clinically relevant. So there are studies that have shown that people who walk with higher CAM parameters are at increased risk of having greater symptoms and having greater X-ray disease severity. They're also at risk of having greater structural disease progression, and in a study that we did when we followed patients over 12 months, those who had higher CAM parameters at baseline were much more likely to show greater loss of medial cartilage volume as measured on MRI. They're also at increased risk of having to have a joint arthroplasty down the track. So again, as you can see, it certainly is related to clinically relevant outcomes. So it's logical then that researchers have said, well, can we use biomechanical treatments that target the CAM to improve pain and slow disease progression at the same time to hopefully reduce the need for costly joint arthroplasty? So there are a number of treatments that are out there that may have an underpinning biomechanical mechanism, and I'm just going to discuss some of these, and these are the ones that we've been looking at mostly in our research. So I'm going to cover some of our research, but also the research in the field in this area. So I'll start with exercise. Exercise is a core recommended treatment for all patients with knee osteoarthritis. And that's because there is evidence to show that it is clinically effective. And this was a Cochrane review that we did, where we did a systematic review and meta-analysis, and you can see of 44 clinical trials that have examined different forms of land-based exercise. And exercise has moderate benefits for both pain and function, and small benefits for quality of life. So we certainly have evidence to show that it is clinically effective, but what's it doing biomechanically? Well, studies seem to suggest that there is no effect of exercise on the knee adduction moment. And we did a study where we compared neuromuscular exercise, which is sort of functional exercise in weight bearing, with non-weight bearing quadriceps strengthening. And whilst both forms of exercise led to similar benefits for pain and function, you can see from the graph that there was no effect on the knee adduction moment. And other studies as well, looking at various other forms of exercise and strengthening, have also found no effect on the knee adduction moment. And there are less studies that have used structural outcomes in terms of what the effects of exercise are, but they have also found that exercise doesn't affect structural disease progression. So whilst it has clinical benefits in terms of pain and function, it doesn't seem to slow disease progression, unfortunately. But on the other hand, it doesn't lead to increased structural disease progression, which is what some patients and clinicians think. So there's been a lot of work looking at shoe insoles, and in particular lateral wedge insoles for medial compartment osteoarthritis. And these are very simple interventions, they're very cheap, and they're insoles that are higher on the lateral aspect, and they're placed into the shoe. And what we've shown that they do is that they shift the centre of pressure laterally, and they have various biomechanical effects that lead to a reduction in the knee adduction moment. And you can see here from research, this is of 30 participants with and without their lateral wedge insole, and this is the change with the insole. And you can see that the majority of people have had a reduction in the knee adduction moment, and it's on average around about 6%, which would be a clinically relevant amount in terms of structural disease progression. But you can also see that there's great variability amongst participants. You can also see that, what's happening here? That some participants even had an increase in the knee adduction moment. So the response is not necessarily the same. But what effect then? We know that they have biomechanical effects, and these systematic reviews also back that up, where they've pulled the results of all of the biomechanical studies and confirmed that they do have biomechanical effects that we would deem to be positive for patients with knee osteoarthritis. But what about clinically? What effects do they have? So we conducted a large randomised controlled trial where we took 200 participants with knee osteoarthritis, and we randomised them into a lateral wedge insole group and a group that had control insoles. So patients didn't know which group they were in, they didn't know what we were testing, and that was so that we could blind participants and overcome that placebo effects of expecting a benefit. And they were asked to wear them full-time every day in their shoes for 12 months. And then we measured pain, we measured structural disease progression, and a number of other factors. But unfortunately, we found that the lateral wedge insoles compared to the control insoles had no effect on knee pain, and nor did they influence structural disease progression measured by MRI cartilage volume. And those results have also been confirmed by systematic reviews and meta-analysis as well, pooling the results of other clinical trials that have also found that when you compare the insoles to control insoles, that there's no effect on pain. So why is this? Why have we got biomechanical effects but they haven't translated into effects when we look at clinical trials, which is what's going to be needed to influence clinical practice? Well, we've sort of taken people with osteoarthritis as a homogenous group, but we know that it's not, that people with osteoarthritis are a very heterogeneous group and they have a lot variable presentations. And so maybe when we take everybody together, we don't find treatment responders. And so this particular study published by David Felsen, it was a randomised controlled trial. So what they decided to do was to undergo pre-screening first biomechanically. So they got people into the lab and they looked at their response to the lateral wedge insoles, and they only included participants if they showed a greater than 2% immediate reduction in the knee adduction moment with wedges, and then those people were enrolled into the clinical trial. It was a crossover trial, and what you can see is that there were greater benefits for pain reduction with the lateral wedges compared to the control wedges. However, the amount of reduction in pain was relatively small and may not necessarily be clinically meaningful, even though it was statistically significant. But I think it does highlight that we need to be looking at patient subgroups when we are testing these, because it may not be that everybody responds the same way. But nonetheless, at the moment, clinical guidelines don't recommend lateral wedge insoles, because even though biomechanically they're having good effects, we need to be able to demonstrate that clinically in gold standard randomised controlled trials. So then researchers thought, well, the lateral wedge insoles aren't really doing what we want them to do, and the problem is you're putting them into participants' shoes, which can then interact and may change the biomechanical effects. So why don't we look at insoles? And I think it's a bit, this links well with Irene Davis's talk we heard the other day, where they were looking at footwear for running. So we and others have been looking at footwear for walking in people with osteoarthritis. So looking at footwear, we know actually that wearing shoes actually increases the knee adduction moment. So from the knee's perspective, it's probably better if we all walk around bare feet. But probably not a good idea for patients, particularly over here in the cold winters. So we need to have a look at, can we modify footwear, or can we choose footwear styles that increase the cam the least, or are more like barefoot walking. And we know from work that we've done that there is a 7 to 13% increase in the cam wearing shoes compared to bare feet, depending on the type of shoes. So there are 3 main shoe styles that we've found that can actually reduce the knee adduction moment. And the first style is flat flexible shoes, or minimalist footwear, as Irene Davis was talking about, for impact loading for running. So these shoes are lightweight shoes that have thinner, flatter, more flexible soles. And work has shown that they can lead to a 12 to 16% lower cam when you compare them to sort of stiff leather shoes with wider base heels. And our work by one of our postdocs, Cade Patterson, showed that you can have an 8% lower cam than when you compare them to the participants' own shoes that they would normally use. And on this graph here, what I've done is I've plotted the mean percent increase in the knee adduction moment compared to baseline from a whole range of different studies that have looked at different types of footwear. And I've categorised them into ones where they would be more likely to be called sort of flat flexible shoes versus shoes that more fit into a stable supportive category. And you can see that the flat flexible shoes have much smaller increases in the knee adduction moment compared to barefoot, compared to the studies where they're looking at other shoes that would be more considered stable supportive shoes. And in particular, what you want to avoid if you're a patient with knee osteoarthritis is high heel shoes. As you can see from the study by Kerrigan, a 25% increase in the knee adduction moment when you're wearing high heels. So again, clinically, biomechanically, we know that they have different effects. In terms of looking at what we know from randomised controlled trials, there's only one trial that has looked at the effects of flat flexible shoes on knee symptoms. None yet that have looked at structure, but this was a study by Tromboni Souza, and they tested one particular flat flexible shoe. It was this shoe here that they said was very cheap, $6 US, perhaps not to everybody's liking, but they tested this shoe in 56 women with mild to moderate medial knee osteoarthritis, and they were asked to wear it for 6 months, and they compared it to a group who were wearing tennis shoes, which would be considered a stable supportive shoe. And you can see over the 6 months of daily use that there was significantly greater reduction in pain with the flat flexible shoe compared to the control shoe, around about 2.5 times greater improvement. But also to highlight that you can get some improvement with the control shoe, and that probably also largely reflects that placebo response that I mentioned before. So some indication here that we can get some clinical benefit. And we're currently finishing off a randomised controlled trial. I don't have the results, unfortunately, but led by my colleague Rana Hinman. So rather than just testing one particular type of shoe, in order to increase the generalisability, we're randomising patients into wearing flat flexible shoes or into a group that wear stable supportive shoes, but they can choose from a whole range of shoes that we've categorised into those particular types, which will, as I said, increase the generalisability of the results. The second type of shoe style that can reduce the knee adduction moment is variable stiffness shoes. And these have been developed specifically with the aim of unloading the knee in that medial compartment. And this was one shoe that was developed at Stanford, and a shoe that we developed in conjunction with ASICS, the footwear company. And these shoes have a variable stiffness so that they're laterally stiffer in the midsole compared to the medial aspect. So what it does is it actually forces the person's foot into eversion or into pronation, which is opposite to what the stable supportive shoes aim to do. And in our particular shoe with ASICS, we added in a wedge sock liner as well. And the studies show that you can reduce the cam compared with a constant stiffness control shoe by about 5%. And in our shoe, we were able to have the reduction at 8% compared to a control shoe by adding in that wedge sock liner to the variable stiffness shoe. But importantly, the group from Stanford also used a participant who had a implanted knee joint replacement so that they could directly measure medial contact force. And so they confirmed in this in vivo study that there was a 12% reduction in medial contact force compared to the person's own shoes. So again, certainly you can get reductions in load with these shoes. And this was work from our group done by our postdoc at the time, Crystal Keane. There's been 2 randomised controlled trials now testing the shoes. The one from Stanford by Earhart, they tested 79 people with medial knee osteoarthritis. They were asked to wear them for 6 months. However, they didn't find any difference in the primary outcome between groups, which was a WOMAC score, a self-reported score. But they did find that 71% of the intervention group had a clinically relevant improvement in pain compared with only 35% in the control group. And interestingly, what they also found is that after the participants had been wearing them for 6 months, the reduction in the cam with the shoe was greater than they'd measured at baseline. So perhaps the more you wear the shoe, the greater that biomechanical benefit. We also conducted a randomised controlled trial of our unloading shoe in 160 patients with knee osteoarthritis, randomised into the ASICS unloader shoe and compared to a control shoe. And again, participants didn't know that we were testing these different types of shoes, so they were blinded to shoe type. And they wore them for over 6 hours a day for 6 months. However, what we found was whilst both groups had clinically meaningful improvements in pain, there was no significant between group differences. So again, why didn't we find a difference in that group? We then wanted to have a look at the subgroup, whether there were subgroups of responders, and our postdoc, Cade Patterson, did some exploratory analyses, moderator and mediator analyses to look at that, to see whether perhaps certain groups of people did show a response that we don't see when we put everyone together. And what we found was that disease severity was indeed a moderator of the effect. And we found that in the unloading shoes conferred greater symptomatic benefits over the conventional shoes in people that had moderate to severe knee osteoarthritis, whereas those that had the mild disease actually did better in the conventional shoe. So we're getting these subgroups of people that do respond. And what he did also find was that the pain effects that we saw were mediated by the reduction in the peak cam. So showing that there is a biomechanical rationale underpinning the pain benefits that we were seeing in this group. The last shoe style that has been shown to have some biomechanical benefits in terms of reducing the cam is the rocker bottom unstable shoes that were quite popular a little while ago, perhaps not as popular nowadays. But these are shoes that you see with a sort of a convex curved sole in the sagittal plane. They also have a reduced sole density. And some work by our master student, Liz Madden, showed that they significantly lowered the peak cam by about 7%, but however, it still remained higher than barefoot walking. She also found, importantly, that there was no increase in the knee flexion moment, which would be important. You don't want to decrease something, but just increase something else that's going to counteract that benefit. And she had a look at the mechanisms underpinning this reduction in the knee adduction moment. And there's been one clinical trial looking at the effects of these on pain, and this was done by Bennell in 2006, and it was a 12-week study where they randomised 123 people with knee osteoarthritis, and they compared the MBT rocker sole shoe with a control shoe. Again, finding that both groups improved pain, but there was no difference between the groups. So again, not able to sort of translate the biomechanical findings to a clinical benefit. So clinical guidelines currently, and this is a quote taken from the EULAR guidelines, the European League of Rheumatology, and they say that we should be recommending thick shock-absorbing soles for our patients with knee osteoarthritis. However, based on the research now, the biomechanical data and some of the emerging clinical data, we would actually think that that's the exact opposite. And Cade Patterson also did a survey of patients around what they're being told by clinicians, what are clinicians saying to them, what shoes are they wearing. And in actual fact, again, it holds that clinicians are telling patients that they should be wearing shoes that promote foot stability. They should be wearing these conventional athletic footwear, which again is opposite to what we would be advising. We really probably should be advising sort of more flat, flexible, minimalist shoes than these stability shoes. And if you ask patients to bring in their own shoes and you look at what they are actually wearing, patients themselves believe that they should be wearing stable supportive shoes, and this is what they bring in, and you can see that they're very reflective of stable supportive shoes. So again, if we want to then change practice and patient outcomes, we also need to be doing research to look at how we can change clinician and patient behaviour. So I'm now going to finish off with sort of gait modifications and walking aids. But there's been a lot of interest in gait modification strategies, and there's been a lot of talk here at this conference and some research presented about gait retraining for knee osteoarthritis, and it was also really good to hear Irene Davis's lecture and look at gait retraining for runners. And so one of our PhD students a while back, Milena Simic, did a systematic review to look at what was out there in terms of gait retraining or gait modification strategies for reducing the knee adduction moment. And what she found at the time, and there'd be many more now, but she found that there was about 24 studies at that time that had evaluated 14 different gait modifications. So you can see here there was a wide range of targets that people were looking at to try and reduce the knee adduction moment. But the ones that were, I suppose, most studied has been lateral trunk lean to the same side, so it's an ipsilateral trunk lean to the affected knee, and sort of a toe-in or a toe-out gait. And we know that these can influence the knee adduction moment. Just some work that she did where you give people some real-time biofeedback and you ask them to lean different amounts. She got them to lean at sort of 6, 9 and 12 degrees. And you can see here that you are able to reduce the knee adduction moment with varying amounts of trunk lean. And similarly, you are able to change the knee adduction moment with different amounts of foot angle progression. So certainly we're able to change the knee adduction moment immediately in the lab with some biofeedback. But it might be that personalised gait retraining is going to be better than simply giving everyone the same. And this was, I thank Scott Ulrich from Stanford. He gave me one of his slides that he presented here at the conference, where they showed that if you actually personalised the toe-in or toe-out to the patient, 70% of the participants were able to gain a reduction in the CAM of 5% or more. Whereas if you make everybody do a uniform, for example, 10% toe-in or a uniform 10% toe-out, far fewer percent of the participants are able to reach that reduction in the CAM. So it probably needs to be personalised gait retraining. And other studies have also shown that maybe you get better reductions in the knee adduction moment if you allow the patient to choose their own strategy to reduce the knee adduction moment. So rather than force them to do toe out, they may choose their own lean, or they may combine it, and that might be better as well. But in the literature now, there's a lot of different studies that are out there, and people are using different ways to provide the feedback in the lab. There's, at Aussie, there was some where they were using a mobile phone from a sensor in the foot to then go to some auditory feedback. People have been using a treadmill, virtual reality treadmill, and giving visual feedback. Others have been using sort of tactile feedback and vibration and so forth. So people are using a range of different feedback techniques and oftentimes in the lab. At this stage, there's only one randomised controlled trial testing a gait retraining or a gait modification program to see can we lead to improvements in pain and function. And this was a study by Michael Hunt's group in Vancouver. They had 79 patients with medial knee osteoarthritis. Half of them did a walking program with the gait modification program, and the other half just did the gait walking program. They were trained to walk with a standard amount of toe out. It was 15 degrees, and they just used simple training, like a feedback with a treadmill and a mirror, something that would be able to be translated into the clinic down the track. And they had 8 training sessions with the therapist. And unfortunately, whilst immediately after the 4-month training program they could find reductions in the CAM and they could change that foot progression angle, by 5 months, so 1 month later, The improvements in the CAM had been lost, and neither of the groups showed any difference between them in terms of pain and function. They did improve pain and function, but the addition of that gait retraining didn't affect pain and function. And it may be because there wasn't enough training perhaps at home, it was only done in the clinic, or that everyone got the standard training. So certainly there needs to be a lot more work before we're able to take something like this into clinical practice. And I think there are a number of issues that need addressing. Firstly, how do we select the appropriate patients? As I mentioned before, maybe it's not relevant for every patient with knee osteoarthritis. Maybe there are the biomechanical patients and those that have a much more inflammatory phenotype. This isn't going to be effective. So how do we select those appropriate patients? What gait parameters do we target? Do we target trunk lean? Do we target toe out? What do we target? How can we provide feedback in the wild? And I know that there was a lot of sessions here around wearable technologies, and I think they are going to be the way forward. They need to be things that patients can take home and do in their own home. They can't be coming back for multiple sessions with a therapist. They can't be coming into a lab. It needs to be something that they can do in the home. Can we achieve permanent changes? Again, it's all very well if they can do it, but they need to become habituated. Are there beneficial clinical effects? Again, no point if it doesn't translate into improvements in pain and then perhaps structural changes. Are there any negative effects at other joints? And we always get people saying, but if you're making them lean, for example, isn't that going to be bad for their back? And then really importantly, and this is where I think, linking up with clinicians, the training program, is it going to be something that down the track could be feasibly rolled out and delivered by clinicians? So now just to finish off with the last point, and this is around, or the last strategy, is looking at walking aids. Again, something that clinical guidelines recommend, basically not because there's a lot of evidence, but because they think theoretically they should be effective. And walking sticks, we've known from our work and others that if you hold the stick in the opposite hand, you can get large reductions in the knee adduction moment during walking. And this was Milner's work. We had an instrumented cane, and patients put varying amounts of body weight support through the cane, and you can reduce the knee adduction moment. So we then wanted to use this as a model to test the hypothesis then, well, surely if we reduce the load going through the knee, we should be able to measure structural changes in patients that use this. So we conducted a randomised controlled trial, and Ans van Ginkel, who was our postdoc at the time, who's gone back to Belgium now, and she won the Young Investigator Orsi Award for this paper, so that was really great for her. But what we did was we wanted to use the cane to see whether we could improve pain, but importantly, could we change structure? And we wanted to measure structure using bone marrow lesion volume change, and we used Jeff Duria's software from Harvard to do that. And so we taught patients in that cane group how to use it using the instrumented cane so that they could get feedback on how to use it correctly, because when you firstly give someone a cane, they're not very good at using it. So there was training sessions on how to use the cane correctly to unload the knee. And then they were asked to use the cane whenever they were walking every day for 12 weeks. And the really good thing about bone marrow lesions is that unlike cartilage volume on MRI, which takes about, you need to measure that over 12 months or more, bone marrow lesions can show changes much more rapidly, even as little as 6 weeks. And the other important thing is that bone marrow lesions have been shown to be highly correlated with pain and also correlated with structural progression over time and need for joint replacement and so forth. So they're a good measure of structure that you can measure much more quickly. However, after the 12 weeks, when we compared the cane group with the non-cane group, unfortunately there was no difference between the groups either in knee pain or on these bone marrow lesions. Now again, is that because we included everyone? Not everyone should have that. Is it that the measure of the bone marrow lesions wasn't sensitive enough because there was quite a lot of variability in that measure? Nonetheless, we obviously need to be understanding why we're not finding necessarily the results from the biomechanical research through into the clinical outcomes. So I want to leave it there and really sort of just in summary to say that I hope I have shown you that biomechanical research can be really important in informing and guiding our clinical research to hopefully then come up with treatments that are going to be clinically useful. And for me, the biggest part is that the collaboration between, hardcore biomechanical researchers and clinical researchers and patients and clinicians is highly beneficial. And I've really valued our work with our biomechanists, other people like David Lloyd and Griffith and so forth too, so that we could all come together, because oftentimes our biomechanists will say something and we'll say, well, that's never going to work clinically. So I suppose I want to be here to really encourage you to join with clinicians and clinical researchers as well to ensure that we take the biomechanical research to impact patient outcomes. And finally, just to acknowledge, this is our current team at the Centre for Health, Exercise and Sports Medicine, fantastic team who do all the work, but also all of the people in the past who have been through our lab, both students and postdocs, and all of the collaborators for whom we wouldn't be able to do any of this work. So thanks again for waiting till the last day and the last few sessions of the conference, and safe travels to everyone. Thank you.